All right, welcome back to the deep dive. And today, we're doing something a little different.
A lot different, I'd say.
Yeah, we're not just, exploring a topic. We're stepping right into the exam hall. We're simulating a very intense prep session for a postgraduate student getting ready for their Gujarat University MD anesthesiology exams.
That's right. And for that reason, you can think of me as your senior faculty today.
Oh.
I'm going to be very strict on the physiology. I'll be listening for specific keywords, and I'll point out exactly where candidates tend to go wrong and where the top marks are. This isn't a casual chat. This is about getting you ready to face that examiner.
I'm ready for the Viva, Professor.
Mm-hmm.
So today's mission, we're tackling two absolute cornerstones of obstetric anesthesia. These are topics that, well, they come up all the time. Long questions, short notes.
The dreaded table Viva.
Exactly. We're talking about supine hypotension syndrome and, on the other side of the coin, Mendelson syndrome.
Correct. And there's a good reason we pair these two. They really represent the two great physiological threats to a pregnant patient. You have the circulatory collapse of supine hypotension syndrome, and then you have the respiratory catastrophe of Mendelson's.
So it's circulation and breathing, A and B or C and A, B.
Precisely. The examiner uses these topics to see if you genuinely understand the why, the physiological changes of pregnancy. If you can't explain the mechanism, you can't manage the patient, and, well, you certainly won't pass the station.
Understood. We have to nail the pathophysiology. So let's start with part A on our outline, supine hypotension syndrome.
Let's begin.
Okay, so I'm in the exam. The question's on supine hypotension syndrome, or as it's often called, aortocaval compression. How do I start? What's the perfect introduction?
You start with a very precise, very clear definition. You say, supine hypotension syndrome is the profound hypotension that results from the mechanical compression of the inferior vena cava and the abdominal aorta by the gravid uterus when a pregnant woman lies in the supine position.
And this is something that only happens late in pregnancy, isn't it?
Generally, yes. It becomes clinically significant after about 20 weeks of gestation. Before that, the uterus just isn't big enough to cause a major problem.
Okay.
But here's the first bit of nuance for your answer. This is important. While some degree of IVC compression happens in almost all term parturients when they lie flat.
In everybody.
In nearly everybody. But the actual symptomatic syndrome, where the patient feels dizzy, feels sick, or even loses consciousness, that only occurs in about, say, 8 to 15% of women.
So that's a critical distinction to make. The compression is anatomical and almost universal at term, but the syndrome is the physiological failure that happens in a minority.
Exactly. And you must state that. If you just say every pregnant woman gets the syndrome, you've already made a mistake. Every woman gets the compression. Only some get the syndrome.
Which leads us perfectly into the physiology. This is marked as very high yield on our plan. So walk me through it. What is physically happening?
Picture the anatomy. It's simple mechanics. You've got the lumbar vertebrae right down at the L5 level. Running right in front of that spine, you have the big vessels. The inferior vena cava, the IVC, slightly to the right.
And the aorta to the left.
And the aorta to the left. Now, you place a heavy, full-term gravid uterus on top of them. It's like putting a bowling ball on a garden hose.
It's just a mechanical obstruction.
Purely mechanical. The first and most significant event is the compression of the IVC. It's a low-pressure, thin-walled vessel, so it squashes easily.
And that stops blood from the lower body getting back to the heart.
Correct. It impedes venous return. When your venous return plummets, your preload, the amount of blood filling the heart, also plummets. And according to the Frank-Starling law, if preload drops, what happens next?
Stroke volume drops, and then cardiac output drops.
Yes. And we're not talking about a small drop. In the supine position, cardiac output can fall by 10 to 20% compared to when the patient is lying on her side. That is a huge hemodynamic change.
But you just said most women don't get symptoms.
Mm-hmm.
A 20% drop in cardiac output, I definitely feel that. So why don't they?
This is the exam save. This is the detail the examiner is listening for. The body has a backup plan.
Okay.
It's called collateral circulation. When the main highway, the IVC, is blocked, blood finds the side roads to get back to the heart.
What are these side roads?
It diverts through the paravertebral veins running alongside the spine, through the intraosseous veins within the vertebral bones, and most importantly, through the azygos venous system. You must mention the azygos system.
The azygos system. Okay, so In those asymptomatic women, these collateral pathways are efficient enough to handle the flow and bypass the blockage.
Precisely. If those collaterals are well developed and, crucially, the sympathetic nervous system is firing on all cylinders, causing vasoconstriction and a faster heart rate, the woman feels fine. She compensates.
And if the collaterals aren't good enough or something blunts that sympathetic response?
Then the syndrome manifests. The system fails.
Now, the name is aortocaval compression. We've talked a lot about the cava. What about the aorta?
Excellent question. The aorta is a high-pressure, thick-walled vessel, so it's much harder to compress than the IVC. But it does happen. The heavy uterus can and does press the aorta against the spine as well.
And what's the consequence of that?
This leads to a reduction in blood flow distal to the point of compression, so less blood flow to the legs, the kidneys,
And the uterus itself.
and most critically for us, the uterus itself. This brings up a concept you should mention, the Pizarro effect.
The Pizarro effect.
Yes, it's a fantastic point for Viva. Because the aortic compression happens below the level where the blood supply to the arms comes off, you might measure the mother's blood pressure in her arm, the brachial artery, and it looks completely normal.
Wow.
But the pressure in the arteries below the compression, like the femoral arteries and, crucially, the uterine arteries, is dangerously low.
That's a terrifying thought. Her arm BP is reading 120/80, but the baby isn't getting enough blood.
That is exactly it. Uteroplacental perfusion is entirely pressure-dependent. The uterine vessels are already maximally dilated in pregnancy. They have no capacity for autoregulation. So if the pressure feeding them drops, the flow drops in a straight line. The mother might look fine for a moment, but the fetus is already in trouble.
Okay, that brings us to the clinical features. If the mother's compensation is failing, what do we see? What does it look like?
It looks like pre-shock or shock. The classic presentation is a woman who lies flat on her back and within a few minutes develops pallor. She starts sweating. She feels dizzy.
And her heart rate?
It can be tachycardia, as you'd expect, but sometimes, and this is a key sign, you can get a paradoxical bradycardia.
Bradycardia. Why would the heart rate go down with low blood pressure?
It's thought to be a vagal reflex, probably the Mizol-Jerish reflex, which is triggered by profound underfilling of the ventricles. But there's one symptom you must mention, as it's often the very first sign.
What is it?
Nausea.
Nausea.
Absolutely. Nausea and vomiting in a supine pregnant patient is your #1 red flag for cerebral hypoperfusion. Never, ever ignore it. If your patient on the table for a spinal says, "I feel a bit sick," your hand should immediately go to the blood pressure cuff and your eyes should go to her position.
And for the fetus, you said it might show signs first.
Yes. As we discussed with the Pizarro effect, the fetus can become distressed before the mother even feels dizzy. You'll see it on the fetal heart rate monitor. Late decelerations, a prolonged bradycardia. The fetus is the canary in the coal mine.
Let's tie this directly to our specialty now, anesthesia. Why is this so incredibly critical for us?
Because we, as anesthetists, have the power to completely destroy the body's natural defense mechanisms.
So.
Remember that compensation we talked about? High sympathetic tone, vasoconstriction, tachycardia. What's the first thing that happens when we perform a spinal or an epidural?
We block the sympathetic nerves.
We perform a chemical sympathectomy, usually from about the T4 level down. We completely wipe out the vasoconstriction in the legs and the splanchnic circulation.
So you have this double hit.
A double hit, exactly. It's a recipe for disaster. You have a mechanical obstruction from the uterus blocking the IVC, plus you've just created widespread vasodilation.
So blood pools in the legs because the vessels are wide open.
And it can't get back to the heart because the IVC is squashed shut.
Wow.
And it's not just regional. If you induce general anesthesia, your induction agents, propofol, thiopentone, they also blunt the sympathetic response. So the moment of induction is a moment of extreme peril.
That sounds like it could lead to a cardiac arrest if you don't manage it proactively, which takes us to prevention, an exam favorite.
The absolute golden rule of obstetric anesthesia, you must say this, never, ever place a pregnant patient after 20 weeks in the fully supine position without some form of uterine displacement. It is mandatory. It is non-negotiable.
And the standard technique is left uterine displacement, or LUD?
Correct. We need to physically move the uterus off the great vessels, particularly the IVC, which is on the right, so we tilt her to the left.
How do we actually do that in the operating theater?
The classic method is to place a wedge, often called a Crawford wedge, under the patient's right hip to tilt the whole pelvis to the left.
And how much of a tilt do we need? The books always say 15 degrees.
For your exam, 15 degrees is the standard correct answer. It's what we aim for. However, If you want to show you've read beyond the basic textbook, you can mention that some recent MRI studies suggest 15 degrees might not be enough to fully relieve the compression in all women.
Really?
Yes. Some data now suggests that a 30-degree tilt might be more effective.
But a 30-degree tilt would make the surgery almost impossible for the obstetrician.
It does, it's a balance. But the clinical point is, if your 15-degree tilt isn't working and the patient's blood pressure is still crashing, you need to tilt her more. Or you need to manually displace the uterus.
Manually displace, you mean with your hands?
Yes. Someone, usually an assistant or the anesthetist, stands on the patient's left side, reaches across, and physically cups the uterus and pulls it upwards and to the left. It's often much more effective than just tilting the table. And it is absolutely essential during CPR in a pregnant patient.
Okay, let's move to management. Let's run a scenario. I've just done a spinal for a C-section. The patient is tilted. Suddenly, her blood pressure drops to 80/40. What are my immediate steps?
First principles. Step 1. Check and increase the tilt. Is she actually tilted or has she slid back? Tilt her more. Step 2. Fluids. Should already have a line running. Open it up. We call this co-loading, giving a fluid bolus as the spinal is taking effect.
And step 3 would be vasopressors. This is always the big debate, isn't it? Ephedrine versus phenylephrine. Historically, we were all taught ephedrine was the drug of choice.
We were, and for a long time it was. The thinking was that its beta-adrenergic effects would maintain heart rate and cardiac output, and animal studies suggested it preserved uterine blood flow. But that dogma has completely changed.
So what's the current exam standard?
The current standard, supported by all the major texts like Miller and Morgan, is that phenylephrine is the preferred first-line agent for treating spinal-induced hypotension in pregnancy.
And why the switch? What's wrong with ephedrine?
The problem is that ephedrine freely crosses the placenta. It acts like an adrenaline shot for the fetus. It stimulates the baby's metabolism, causing it to burn through energy reserves much faster.
And that leads to?
It leads to the production of lactic acid and other metabolic byproducts. In short, it causes fetal acidosis.
So ephedrine makes the baby acidotic.
Yes. Phenylephrine, on the other hand, is a pure alpha agonist. It works by increasing maternal systemic vascular resistance, which brings the blood pressure back up. It doesn't cross the placenta in significant amounts, and it doesn't cause that metabolic stimulation, so it maintains the pH of the fetal blood much, much better.
So for the exam, phenylephrine is preferred to avoid fetal acidosis. That's the key phrase.
That is the gold medal answer. The only time you might still reach for ephedrine is if the mother is profoundly bradycardic. But as your default go-to drug, it's phenylephrine.
Very clear. Okay, that wraps up supine hypotension syndrome. Let's switch gears to the respiratory nightmare. Part B, Mendelson syndrome.
Yes, a topic with a lot of history. Curtis Mendelson first described this back in 1946, linking aspiration to maternal mortality.
So how do we define it for the exam today?
Mendelson syndrome is a chemical pneumonitis. It's not an infection. It's a chemical burn of the lungs caused by the aspiration of acidic gastric contents.
And there are specific criteria for that, aren't there?
Yes, the classic criteria you must state are a pH of the aspirate less than 2.5 and a volume of more than 25 milliliters, which is about 0.4 milliliters per kilogram.
pH 2.5, volume 25 milliliters, easy to remember. So why is this such a major issue in pregnancy? What's the pathophysiology here?
It's what I call a perfect storm of mechanical and hormonal factors. First, mechanically, the huge gravid uterus pushes the stomach upwards. It rotates it, which changes the angle of the gastroesophageal junction, making reflux easier, and it dramatically increases intra-abdominal pressure. It's literally squeezing the stomach.
Okay, that's the mechanical part. What about hormones?
The main culprit is progesterone. Progesterone is a smooth muscle relaxant. This is great for keeping the uterus from contracting prematurely, but it's terrible for the lower esophageal sphincter, the LES.
It makes it floppy.
Exactly. The tone of the LES is significantly reduced, so the valve at the top of the stomach is weak, making it much easier for stomach contents to regurgitate back up.
Now, what about gastric emptying? You hear a lot of conflicting things. Does pregnancy itself delay it?
This is a very, very important Viva point. During pregnancy itself, without labor, gastric emptying is generally not significantly delayed. It's more or less normal.
Oh, okay.
However, the moment labor begins, everything changes. Pain, anxiety, and especially the use of opioids for pain relief can completely shut down the stomach. Gastric emptying stops.
So for all practical purposes, any woman in labor has a full stomach.
For exam purposes and for clinical safety, you must always assume that every pregnant woman, especially if she's in labor or needs an emergency procedure, has a full stomach. Full stop.
And if they do aspirate that stomach content, What's the actual mechanism of injury to the lungs?
It is a brutal chemical burn. The acid makes contact with the alveolar capillary membrane and destroys it almost instantly. This causes a massive inflammatory response and makes the capillaries leaky.
So fluid pours into the lungs.
Fluid pours into the alveoli, causing a chemical pulmonary edema. The acid also destroys surfactant, which is the substance that keeps the alveoli open, so they collapse, a condition called atelectasis.
And that causes a massive VQ mismatch.
A massive shunt. You have blood flowing through parts of the lung that have no oxygen in them. It's catastrophic for oxygenation.
So the clinical features. How would a patient present?
It's usually dramatic and immediate. The patient aspirates, and you may instantly hear wheezing from intense bronchospasm. They become hypoxic very quickly. You'll see the oxygen saturation plummet. They'll be cyanotic, gasping for breath.
And you might see sputum.
Yes, the classic sign is pink, frothy sputum, which is the hallmark of acute pulmonary edema. The whole clinical picture can look like a massive heart attack or a pulmonary embolism. The hypotension can be so severe it looks like anaphylactic shock.
What about on a chest x-ray?
On an x-ray, you might see diffuse, patchy infiltrates, sometimes described as a snowstorm appearance. It's often unilateral and more common on the right side because the right main bronchus is straighter and wider than the left.
Okay, let's talk risk factors.
Yeah.
In our obstetric patients, who is most at risk for this?
Well, anyone having emergency surgery, especially an emergency C-section where there's no time for fasting, obesity is a major risk factor. But from an anesthetic perspective, the single biggest risk is a difficult airway.
A failed intubation.
Exactly. If you give induction drugs, the patient loses their protective airway reflexes, and then you can't secure the airway quickly with a tube. That is the highest risk scenario for aspiration.
So prevention is everything, and this is where the exam marks are won and lost. Let's talk about the pharmacological prophylaxis, the prophylaxis triad.
Right. You have to attack this problem from 3 different angles. 1, neutralize the acid that's already there. 2, stop the stomach from producing more acid. And 3, try to empty the stomach.
So number 1, antacids.
Specifically, 0.3 molar sodium citrate. The standard dose is 30 milliliter given shortly before induction.
And why sodium citrate? Why not just give them a bottle of Gaviscon or some other over-the-counter antacid?
This is a classic Viva trap. You must use a non-particulate antacid.
A non-particulate. Why?
Because if you give a particulate antacid, one with chalky bits in it, like magnesium trisilicate, and the patient aspirates that, the particles themselves cause a devastating inflammatory reaction in the lungs, a granulomatous pneumonitis. It can be even worse than the acid burn.
So the treatment becomes a poison.
Precisely. Sodium citrate is a clear liquid. It does the job of neutralizing the pH instantly without adding any solid matter.
Got it. Non-particulate is the key phrase. Okay, number 2, stop acid production.
That's your H2 blockers, like ranitidine or famotidine, or a proton pump inhibitor like pantoprazole. These stop the parietal cells in the stomach from secreting more acid. But you have to remember, they take time to work.
They don't affect what's already in the stomach.
No, they take at least 30 to 60 minutes to have an effect, so they're great for elective cases, less useful in a true emergency.
And number 3, prokinetics.
Metoclopramide, usually 10 milligram given intravenously. The idea is it increases the tone of that leaky lower esophageal sphincter and also speeds up gastric emptying, moving contents out of the stomach and into the small intestine.
So that's the drug cocktail. What about our anesthetic technique? How do we prevent it there?
The absolute best prevention is to avoid general anesthesia altogether. Choose regional anesthesia. If the patient is awake, her airway reflexes are intact, she can protect her own airway.
But sometimes you have to do a GA.
Sometimes you must. And if you do, the technique has to be a flawless rapid sequence induction, or RSI.
And RSI absolutely includes cricoid pressure.
Yes, Selleck's maneuver. Now, there is some debate about its efficacy in the wider literature, but for your obstetric anesthesia exam, the answer is you apply firm cricoid pressure. It's the standard of care. The goal is to occlude the esophagus and prevent passive regurgitation during that vulnerable period between loss of consciousness and securing the airway.
Okay, the worst has happened. We witness an aspiration. Management. What do we do?
Immediate airway protection is your priority. Tilt the patient's head to the side, suction the oropharynx thoroughly. But don't waste precious time trying to blindly suction the trachea. The most important thing is to intubate. Secure the airway with a cuffed endotracheal tube as quickly and safely as possible.
Once the tube is in and the cuff is up?
100% oxygen. And then you need to apply PEEP positive and expiratory pressure. This is critical. PEEP helps to recruit those collapsed alveoli and push the edema fluid back out of the air spaces, improving oxygenation.
What if they've aspirated solid food?
If you suspect particulate matter, you'll need to perform a bronchoscopy to clear the airways. A rigid bronchoscope is often better for removing large chunks of food.
What about drugs? Can we give steroids to dampen the inflammation?
Another Viva trap. The answer, based on current evidence, is generally no. Routine prophylactic steroids are not recommended. They haven't been shown to improve outcomes, and they might increase the risk of secondary infection.
And antibiotics?
Same story. You don't give antibiotics prophylactically for the chemical burn. You only give them if and when the patient develops signs of a secondary bacterial pneumonia, usually a few days later. The initial management is purely supportive.
So it's oxygen, PE, and supportive ICU care.
That's the core of it, yes.
Okay, let's move to part C. This is where we tie it all together for the examiner. Comparison and exam integration.
Yeah.
How would you compare these two syndromes in a Viva?
You should be able to rattle this off. Imagine a table in your head.
Column A, supine hypotension. Column B, Mendelson's.
First line, system affected. SHS is cardiovascular, a circulation problem. Mendelson's is respiratory, an airway and breathing problem.
Okay.
Next line, pathophysiology. SHS is a mechanical compression leading to preload failure. Mendelson's is a chemical burn from aspiration leading to alveolar damage.
What about the role of patient positioning?
That's a great point of comparison. For SHS, the supine position is the cause, and moving to the lateral position is the cure. The fix is mechanical. For Mendelson's, the supine position is a risk factor, but once the aspiration has happened, turning the patient on their side doesn't fix the lung injury. The damage is already done.
And prevention strategies are completely different.
Completely. SHS prevention is purely mechanical. Use a wedge, tilt the table. Mendelson's prevention is a combination of pharmacology, your antacids and H2 blockers, an anesthetic procedure preferring regional or using a perfect RSI.
So let's think about the overall anesthetic implications. What does this mean for our choice of technique?
It means that for both conditions, regional anesthesia is generally the preferred technique.
For different reasons, though.
Exactly. For preventing Mendelson's, we choose regional to keep the patient awake and their airway reflexes intact. For SHS, we still have to manage the sympathetic block that regional causes, but we avoid all the risks of GA and airway manipulation. So regional wins, but you have to be extremely vigilant.
So with regional, you're trading the high risk of aspiration under GA for the high risk of profound hypotension from the spinal block.
You've put that perfectly. You're choosing which fire you'd rather fight, and the hypotension is generally more predictable and manageable than a catastrophic aspiration.
Okay, let's do some rapid-fire common exam questions in Viva traps. You've mentioned a few already, like the particulate antacid trap. What's another one?
The fluid trap. The examiner will say, you've done a spinal for a C-section, the blood pressure is 70/40, you give a 500 milliliter bolus of crystalloid, the blood pressure is still 70/40. What is your next step?
And the wrong answer is give more fluid.
That's an immediate fail. The answer is, my first action is to check and increase the left uterine displacement. You can pour 5 liters of fluid into that patient, but if the IVC is clamped shut, it's not getting to the heart. You must always think physiology before pharmacology.
Physiology before pharmacology. I like that. Any other traps?
The vasopressor choice we discussed? If the examiner asks you why you chose phenylephrine over ephedrine, you cannot just say it works better. That's not a postgraduate answer. You must mention the mechanism. Avoiding the fetal metabolic acidosis caused by ephedrine's beta agonist effects.
Okay, last point before we summarize. Diagrams. If this is a written exam, what should I be drawing?
For supine hypotension, a simple cross-section of the abdomen at the L5 level is perfect. Draw the vertebral body, draw the aorta and the IVC just in front of it, then draw a large circle on top labeled gravid uterus, showing it compressing those vessels. You could even add a little arrow showing the bypass route via the azygous vein.
What about a flowchart?
Flowcharts are excellent. Draw boxes. Compression, decreased venous return, decreased cardiac output, maternal hypotension, decreased uterine blood flow, antral distress. Very clear, very high yield.
And for Mendelson's?
For Mendelson's, you could draw the airway and show the path of aspiration into the right main bronchus. But honestly, a well-structured table listing the prophylactic drugs, their class, mechanism, and dose is probably more valuable for marks than a complex lung diagram.
Okay, we're at the end of our session. Let's do a final cheat sheet recap. The absolute must-know points.
Let's do it. Rapid fire.
Supine hypotension is aortocaval compression, clinically relevant after 20 weeks.
Prevention is left uterine displacement. 15 degrees is the standard answer.
Management is tilt, then fluids, then vasopressors.
Phenylephrine is the vasopressor of choice to prevent fetal acidosis.
Mendelson syndrome is a chemical pneumonitis from acid aspiration. Remember, pH less than 2.5, volume over 25 milliliters.
All parturients are considered full stomach.
Prevention involves non-particulate antacids like sodium citrate.
Regional anesthesia is the safest technique to avoid aspiration.
If GA is needed, a flawless RSI with cricoid pressure is mandatory.
Management of aspiration is supportive. Secure airway, 100% oxygen, and PEEP. Do not give prophylactic steroids or antibiotics.
And what's the final word from the senior faculty? How do I end my long answer?
Your final message is always about safety and anticipation. You conclude by saying something like, in conclusion, both supine hypotension syndrome and Mendelson syndrome represent significant physiological challenges in obstetric anesthesia. A thorough understanding of their underlying pathophysiology is essential not for treatment, but for proactive prevention. The cornerstone of modern obstetric anesthetic practice is anticipating these risks through meticulous patient positioning, appropriate aspiration prophylaxis, and careful choice of anesthetic technique, ensuring the safety of both mother and fetus.
Always mention prevention before cure.
Always. If you start your answer by talking about how to prevent the problem, the examiner knows you're a safe anesthetist.
That's the motto, then. Keep your patients tilted and your airways secure.
That's the one.
Thank you, Professor. This has been an incredibly valuable session. And for everyone listening, really visualize that wedge under the right hip. Picture the anatomy. You are going to ace this exam. Good luck.
Study hard. You'll do well. Good luck.